Good evening. I'm Sonu Jain at the University of Cincinnati, and I'm excited to welcome you to the American Association for Hand Surgery webinar series. This webinar is just coming off our exciting and successful Hand Fellow Boot Camp in July, and we have outstanding faculty today from coast to coast discussing finished hand fellowship, now what? We'd like to thank ACMED for their generous educational sponsorship of this, and please let me introduce our wonderful moderator, Ines Lin from the University of Pennsylvania. Ines.
Thank you very much. Let me just share my screen here. So I just want to welcome you all to this webinar and thank you for taking the time out of your busy schedules to attend this. As Dr. Jain said, I'm from the University of Pennsylvania in Philadelphia, and as part of the Hand Surgery Fellowship faculty, August is an exciting month. We just said goodbye to our graduating fellows, and we welcomed in new fellows who have been working with us for a month already. And this webinar is really timely with that in terms of celebrating and focusing the transition from fellowship to practice. And we have a great panel of speakers to cover this important topic. First, Dr. Jordan Greer is going to discuss preparing for orthopedic surgery boards. Dr. Greer is in practice with OrthoCarolina in Charlotte, North Carolina. Next, Dr. Paul Gharib is going to present on preparing for plastic surgery boards. Dr. Gharib is an assistant professor in plastic surgery and orthopedic surgery at Emory University. Next, Dr. Kate Hinchcliffe is going to discuss building and managing your team, and Dr. Hinchcliffe is an assistant professor in plastic surgery at University of California at San Diego. Our fourth speaker is Dr. Keith Aziz, discussing clinical documentation and billing, and Dr. Aziz is a senior associate consultant at Mayo Clinic in Jacksonville, Florida. Next, Dr. Steve Niedermeyer will present on professional growth. He is an orthopedic hand surgeon at North Texas Orthopedics and Spine Center in Dallas, Texas. And lastly, Dr. Crystal Tuano will discuss work-life harmony, and she is a hand surgeon at Massachusetts General Brigham in Boston, Massachusetts. So I will now pass it off to Dr. Greer.
Great. Thanks, Ines, and thanks for everybody for joining us this evening. I'm trying to pull my slides here. So I've been tasked with reviewing some of the considerations for preparing for the orthopedic surgery board examination. So in terms of the American Board of Orthopedic Surgery, I think it's important to understand sort of what their charge is and what their role is in the orthopedic ecosphere, that there are a number of different governing bodies that we come into contact with throughout training and that you'll interact with in practice. And the role of the American Board of Orthopedic Surgery is really to ensure safe, ethical, and effective practice of orthopedic surgery for our patients, for the public. So this is different than the charge of the American Academy of Orthopedic Surgery, the American Orthopedic Association, that have differing charges. Really, the goal of the ABOS is to ensure that their diplomats are capable of providing safe, ethical care to the public. When we look at the Part 2 examination, it's an oral exam that's administered after you've completed your ABOS Part 1 exam. So typically, folks will take that ABOS Part 1 examination after completion of their residency training program. And then if they're going out into independent practice or entering a fellowship program, after that Part 1 examination has been complete, you become an eligible candidate for the Part 2 examination. And this is really an assessment of candidates' clinical competence. So unlike the Part 1 examination, where they're really looking to test the breadth and depth of your orthopedic knowledge from a literature standpoint, really the Part 2 examination is looking at you as a practitioner and evaluating your clinical practices, again, looking back at those missions and values of the ABOS in terms of ethical practice and safety. So in terms of being eligible for the exam, this must be taken within 5 years of passing the ABOS Part 1 exam. So after you pass your Part 1, that timeline starts for completion of your Part 2 examination. And you have to have started practice and been granted hospital admitting privileges and surgical privileges on or before November 1st of the candidacy year that you're looking to enter into the program. So that is one thing that is critical, as I know some of those processes have become quite long and arduous in terms of getting the necessary privileges that you'll need. So it's not only being credentialed with your group, getting surgical center privileges, but truly you need to have hospital admitting privileges granted before that November 1st deadline. So that's something to be communicating with your practice and with the hospitals you'll be working with early on to ensure that you have everything in place to get the requisite admitting privileges prior to that window opening, so you don't miss out on the ability to start collecting cases. After that, you'll need to be continuously and actively engaged in the practice of orthopedics in one location for 17 full consecutive months from that November 1st start date. So that runs all the way through March 31st of your examination year. So that is another part of the timeline that really comes into play as you get into practice and start to decide from a different standpoint as to whether or not your current practice situation is going to be ultimately the one that you remain in, or if there are reasons why you may want to move on to a different practice location. You really have to think about how that will impact this timeline, because if you are to change practices or change your affiliations such that it changes from what you initially had at that November 1st granting deadline, and now you are with a different entity, that can affect your candidacy window for the ABOS Part 2 examination. So it's something to really examine carefully if you are in a position where you're considering changing your role or changing your admitting privileges by joining a new group, that this would in turn change your candidacy window. So it's something that you need to be very mindful of if that becomes a realistic concern for you getting into that practice window. In terms of the eligibility window, this has shifted somewhat over the past several years. So now they're collecting your cases between January 1st and June 30th of the year in which you are collecting. So after establishing your hospital privileges on the November 1st deadline, that subsequent January 1st opens your collection window, running all the way through the end of June. And that's a little bit earlier on in practice and earlier on in the year than what was previously done even 2 years ago when my candidacy window was. This will include any of the cases in which you are listed as an orthopedic surgeon of record on the case, and excludes those that you're a co-surgeon or assistant surgeon with another orthopedic surgeon. But this does include any cases that are performed with other plastic surgeons, neurosurgeons, vascular surgeons, for example. So if there is another surgical subspecialty involved in the case in which you're listed as a co-surgeon or assistant surgeon, technically this does not fall within your eligible case list. But if you this does fall within your list. If you are performing these procedures with another orthopedic surgeon, then these will be excluded. So that is one thing that you'll need to look at in terms of how your cases are arranged, cases you're doing with partners, as to whether or not they'll fall on your list. So if you're with another orthopedic surgeon, that case can then be excluded. If you are the sole orthopedic surgeon in that procedure, then it will be included in your ABOS case list. The other thing to consider in this case window is that there are a number of CPT codes that are excluded from the examination case list. So I would familiarize yourself with the list they have on the ABOS website to review those CPT codes that would not be included as eligible codes within the window, because this does include a number of the debridement codes and some other fairly common codes that are being performed, so that you can make sure that if those cases are coming up on your case list when the time comes to certify, that those are removed as they're not eligible to be included. As you're getting through this window, all of your cases should be admitted through the ABOS case dashboard, and you'll begin to receive notifications from the OABOS after you've successfully registered as a candidate for the exam, that you'll have access to their web interface that allows you to input the relevant patient information for each of the cases you've performed that you feel are eligible for inclusion in this window. And that's something that should be done on a fairly timely manner, whether it's at the time of each of the cases completion prior to the case, or sometime at the end of that week, but finding a rhythm in terms of how you're entering those cases to make sure that all of those are being appropriately coded and entered into the system for review later. And then at the completion of your 6-month window, the ABOS will review your 6-month case list and select a total of 12 cases for you to present at your oral examination that coming fall. Unlike prior years, or there was an opportunity for some of the cases selected to be, quote, thrown out, or some that you could choose not to be tested upon. The 12 cases that are selected by the board are non-negotiable. These are the 12 cases that you'll be expected to provide information regarding and present to your board examiners at the time of your board exam. So those 12 cases are chosen, and there's no way to modify those, and there's no cases dropped. When you look at the scoring for the examination, they have a scoring rubric outlined on the ABOS website that I would recommend familiarizing yourself with, both before you go into this process and then certainly as you get closer to the time of your examination, because I think it does a nice job of highlighting all of the different domains on which the examiners will be reviewing your cases and your oral presentation. And you can see that only a small part of that are things like technical skill and things like surgical complications. So it's very easy to perseverate over that one screw on your x-ray that was 1 millimeter longer than you'd like, or the person that was a little bit stiffer at their final follow-up than what you would have liked. But that's not the entirety of how your case will be evaluated. So there is a rubric that looks at each of the different domains on which they will evaluate you, and then the level of confidence they feel that you have achieved within that domain. So it is a fairly robust and comprehensive scoring rubric, and it does allow for you to showcase throughout the entirety of your care for that patient the things that the ABOS would like to see in terms of, again, their mission and safety for the public. So did you gather appropriate data, have an appropriate treatment plan? How is your technical skill? It is a part of it. And then appropriate reporting of surgical complications, outcomes, ethics, and professionalism. So there are good ways to find out what you may be tested upon from a standpoint of what the board examiners are going to look at to evaluate the comprehensive nature of your care for each patient. They also publish on a yearly basis statistics regarding the outcomes of the prior year's examination. And one thing that I would highlight, as much as you want to try to keep things positive today, is that the failure rate of the Part 2 examination is considerably higher than what is noted for first-time test takers for Part 1. So unlike Part 1, where many of us have that feeling when you leave that have that pit in your stomach, it's a difficult examination, but many people go on to do very, very well with the Part 1 examination. The Part 2 examination failure rate is somewhat higher than what we see for the Part 1 exam. So in the last cycle for 2023, the failure rate for the Part 2 exam was 13%. So it is certainly something that you need to be taking into consideration and taking this examination very seriously throughout the entire process. And that starts with establishing good habits going into practice and into your examination window to set yourself up for success when the time comes to present those cases, because that is a very considerable number. And you certainly want to hopefully be in that 80+% that are passing and doing quite well in this exam. But I think it does highlight that the board does take the oral examination and the evaluation of each of these cases quite seriously. So it's one thing to consider very strongly. In terms of preparing yourself, you want to make sure you're doing the best you can to establish safe, sustainable practice patterns for yourself. Doing things in such a way that are reproducible for you, for your team, building rapport with your office and operating room staff, and with your patients really, and trying to get yourself into a good rhythm of performing well-indicated, safe surgical procedures. And then you want to find a way to longitudinally follow the cases that will be eligible for your Part 2 exam. So that means logging them in a timely fashion into the ABOS Scribe platform. And for many folks, I'd also recommend setting up a separate sort of external documentation system for yourself where you can collect and review those cases independent of the Scribe platform to make sure that you're collecting all of the data points that you think you will need to appropriately present that case later. You want to do the best you can to collate all of the associated paperwork with each of the cases. That includes things like surgical consent forms, relevant internal and external clinical documentation. So if there are notes coming in from outside health systems, studies being performed elsewhere, making sure that electronic copies or paper copies of those reports or consultation notes are available so that you have those to present to your board examiners and to help show the work that was done to evaluate this patient and provide appropriate treatment. And then devise a system for patients that are lost to follow-up, that you will invariably have these throughout the course of your examination window. And you need to determine a strategy early on as to how you'll manage that. Is it going to be yourself, your office staff, or is there some system in place within your health system that helps to identify and contact patients that are lost for follow-up, and make sure that you do a good job of documenting that in their electronic medical record regarding a note about their visit, why it was missed, and how they were contacted, whether this was via phone, email message, or if there's other secure messaging platforms that your institution uses. But have a system to document and be able to support that you've tried to reach out to these patients that were lost for follow-up. In terms of things I think are helpful going into this process, try to utilize all the resources at your disposal. So in terms of documentation for your decision making and really making sure you're making the most sound, ethical, and board appropriate decisions for your patients, utilize things like those AOS or specialty society specific clinical practice guidelines. Those are things you can use to your advantage for your decision making, and are also things you may be asked about as part of your examination when the examiners review your cases, if there are relevant clinical practice guidelines to the case you've presented. And review your cases with partners and mentors. If you have particularly challenging cases, you need another set of eyes. If you can have them see them directly, that's great. Even if it's just reviewing the patient's clinical case and imaging documentation with a mentor, do so, do it regularly, and document those discussions. That's something that you can also include in your clinical documentation for the patient, that you have reviewed their care with another board certified orthopedic or plastic surgeon, and include the relevance and need for that discussion. It helps to build the case that you're doing the best you can to devise a safe and effective treatment plan for the patient, and you're not going it alone, so to speak. And then I would suggest taking responsibility for the data maintenance, data entry and maintenance of your own scribe portal. So in some cases, people will elect to have office staff or others in their team manage that data entry and maintenance. And I would tell you that that's really a risk, I think, to do so and not to do that on your own, that there's a lot that goes into maintaining that portal and making sure that things are being updated accurately, whether it's patient demographic information, relevant ICD and CPT codes, or complications as they arise. So I would really, to the best of your ability, avoid reliance on your MAs or AAs and really take responsibility for entering and maintaining that portal on your own. I would also be very careful about templated clinical documentation throughout the board exam period. I know many of us use these. They can help with time and efficiency in clinic, but you want to make sure that everything that's included in there is accurate and relevant to the patient encounter that you're having, and there's not additional extraneous information that may be either distracting or truly inaccurate to the case that's reported, because the examiners will certainly take note of that. And that's one thing that, number one, is just not a good habit. And number two, you'll want to make sure you have the most accurate and relevant clinical documentation available for your case. And this includes things like clinic notes, operative reports, being very careful of your templates, or if you're using those of others, to make sure that they're relevant and accurate to the patient you're taking care of. And then if you're in a situation where you're working with either a physician extender or a trainee, making sure similarly you're going back and reviewing, revising, and attesting any documentation that they have performed in conjunction with you or on your behalf to make sure that it is accurate and it reflects the appropriate treatment plan for the patient that you've reviewed with that other provider. This includes reviewing and signing all of your own surgical consents. So even if the norm is for trainees at your institution to do some of the surgical consent process, throughout your board examination, I would recommend that you review directly and sign all of your surgical consents. I think in general, it's a best practice to be doing regardless, but certainly throughout this period of time, you as the treating surgeon should be signing all of your surgical consents so that you can attest to the completion of these and the inclusion of all of the relevant portions of the operation or implants that you were discussing with the patient. Same thing with inpatient progress notes and operative reports, that in general, these should be things that if you're not doing on your own, you should certainly be reviewing very carefully and attesting to their accuracy and making sure that there's everything included that you did or was supposed to be done for the patient as part of that episode of care. The other things that you'll want to do after you've received your 12 cases are make sure you have access to all the relevant documentation and imaging. So if these are in multiple health systems, if you're in a practice where you're covering not only a private practice or other hospital-based systems, you need to make sure you have access to all of the relevant documentation that you'll need to upload and know who to contact at each of those facilities to get access to the documentation that you'll need. You can consider contacting some of those patients that are selected for longer-term follow-up if it was someone who happened to be lost to follow-up and there is an opportunity to capture another visit with them and document longer-term follow-up if you think it will help with providing a better presentation of their course. And start uploading your relevant documents and redacting those documents as needed early. That process can be quite labor intensive. There's a lot of manual work that goes into redacting the information required if you have not signed waivers from the patients to allow for the inclusion of some of the HPI information in their patient chart. You need to start working on that process early because it can be quite time consuming and labor intensive for you to do. And again, it's something I would recommend you take ownership of and not delegate to other members of your team. It also goes to help build the case summaries that you'll utilize as part of your examination. The first page that will come up on your examination window is this case summary page on which you'll have a multitude of different domains related to that patient case, including their HPI, relevant history, exam findings, imaging, all sorts of things at your disposal that you populate into this form. And if you spend a bit of time doing so on the front end, it will be very beneficial to you as part of the examination, because you can have all of those things available to you on the front page of their chart and won't have to search through the entirety of your book throughout the time that you're with your examiner. And I would be very purposeful in your preparation to review those case summaries, review your clinical documentation and radiographs. You should really know your cases inside and out, know exactly who this person was, what you did to them, why you did it, and how they did, and really rehearse those case presentations independently and do so with mentors, with colleagues, to work on your timing. Try to help get information about relevant questions they might see or some potential pitfalls within the case, things you could be asked about. and have some familiarity with the web-based exam interface. So you'll have an opportunity to use the interface that is used during your examination to review the radiographs that you've uploaded and other specific documents that can be available for digital review as part of the examination process. So I would make sure you're very familiar with the use of that interface and how the timing works. So in general, I would recommend that you do the best you can to very carefully review the timeline for your specific eligibility window, as these have changed somewhat over the past several years, and there's always a chance this may continue to creep earlier and earlier on in your practice, which can affect some of your credentialing as well as your practice patterns to make sure that you are including and start to collate and collect all of the data you need for your cases. You want to do the best you can to establish safe, sustainable practice patterns, not only for your board exam, but also for good patient care and setting yourself up for a good start in practice. Take responsibility for your data entry and ongoing monitoring of the patients that you are treating during your board case collection period. This is of utmost importance that if you are taking care of this patient at any time point during your collection window, you should treat it as though that case is going to get picked, and make sure you do the best you can to collect and review all of the data associated with their case to make sure that everything is tidy. And practice prior to your oral examination. You should know these cases cold by the time you get in there. You should know everything you did for this person and why you did it. Thanks so much.
All right, I am next up. I'm Paul Garib, and I'm going to be talking about the plastic surgery oral board prep. It's pretty similar in some ways to what was just covered, but there are definitely some differences. Let's get right to it. So if you're just getting out of your hand fellowship now, you're probably thinking or looking like this. And this is how I felt leaving my hand fellowship, is where do I even start when trying to prepare for my oral board exam? And the best place to start is the American Board of Plastic Surgery website, and particularly the booklet of information that the board publishes each year. So find the book that is specific to your year that you're going to sit the exam, and I would read it cover to cover. And then once you're done, I would read it again, because it's going to have everything you need to take the exam in it. And you want to make sure you have all the details down before you start collecting so that you're ready to hit the ground running whenever you start your practice. And here's the timeline in general for what it's going to look like when you're starting practice all the way up until your exam. So your case collection period for plastic surgery is going to start on the day you start practice. So July 1st or whenever you start, and then it's going to run through March 31st of the following year. That's your case collection period. April 22nd is the deadline to submit your case logs and other information to the board. So it's about a 3-week period from the time you're done collecting cases to the time you have to send in your case logs with all of the data included in it and with medical records signing off on everything. So it's a very short turnaround here. So it's really important to stay up to date on your case logs and making sure you're having everything ready to go. In the summer and fall, the board will notify you that your case list is appropriate, and they're going to let you sit for the exam. They'll pick the cases for you and notify you of those, and you'll have 5 cases selected. And then that's when you're doing your book preparation. Fall is whenever you're going to be doing book review and studying for the unknown section of the exam, and then your exam is going to be in November each year. Before you start practice, a few tips that I have are, first off, to start with touching base with your coder. Some people don't know who codes for them, and a lot of institutions, they just code in the background and don't even tell you what they're coding for. But I would really encourage all of you to get to know your coder, and I would plan to review all of your codes before they are submitted to insurance to ensure that they're accurate. And if your coding is inaccurate, you are ultimately responsible, both in the eyes of the board and legally. And so it's good practice to review your codes and make sure they're up to date. And it's something that I still do on a weekly basis, even to this day. Then think about your workflow, how it's going to work in clinic and how it's going to work on your operative days or for your inpatient stuff. And for me, that meant creating some simple templates that I could use for common consults, for my hand exam, and for the discussions that I have with patients. You know, let's say the discussion of the risks and benefits of surgery. Having a template for that can just make sure you're hitting and documenting all the points that you need to. And definitely, as was said previously, making sure that it's relevant to the patient. If you're using poorly templated notes, it doesn't help you. But if they're well templated and they're appropriate for the patient, it can make sure that you're documented appropriately. And then think about your other things like the photo consent. That's hugely important and you need for every case that gets selected. So these are examples of my photography consent form, as well as a clinic intake form that I had. So I made sure that I handed every single patient that came into clinic with both of these documents. So I had an intake with basic history history information, and then I had a photo consent for every patient that walked through the door so that if they got picked for the exam, I knew I had it. And then I would create a spreadsheet for all the cases you're going to do for the following year. So I did this in Excel. I think that's very easy to do, and you can update it as you go along with case information, either on a daily or weekly basis. Keeping up to date with this is very important because it's hard to go back at the end of the case collection period and put all this together. Again, at the end of your case collection period, you only have 3 weeks to get your cases into the board. And so keeping up with it as you go is very important. And particularly with things like complication data and outcomes data, when people start to come back to clinic post-op, make sure to go back to the Excel file and update their row with important information because otherwise you might forget. After you start, you should just be thinking of taking good care of patients. I think ultimately, if you're taking good care of patients and you're doing the right thing, that's going to reflect positively when the board examines you. And sometimes you just have to ask yourself, how would this look in front of a board of examiners? If it's reasonable, then I think you're going down the right track. But if it would look crazy to the board, then you may want to reconsider your plan or at least get, phone a friend and ask somebody else for some advice about that case. And then document. No matter what you're doing, making sure the document is incredibly important, either with writing your own notes or if you have a resident or an APP writing notes for you, making sure to go back and addend the notes with your thought process, your assessment, and your plan. So this is an example of a discussion that I wrote after the resident for one of my board cases, where I just went through, listed the problem, listed what my thoughts were, and what we talked about, what the plan was for surgery. It gives the board an insight into your thought process, which is very helpful once you're sitting for the exam. And then take pictures of everything. The pictures are so important and you can't go back to get those pictures later. So making sure you're taking pictures of everything, even if you think you don't need it. So your pre-op pictures, including functional photos, your intra-op pictures, which are required for all cases, and then your post-op function at least 3 months from the time of surgery. So this is one of my cases, rollover ATV. I had to do some extensor tendon work and then cover it with an ALT. So the pictures don't have to be perfect. Of course, as nice as you can make them, it's always good. This was a post-op complication, had a wound infection there. And then these are the ultimate photographs at 3 months with function of the wrists and function of the fingers. So they weren't perfect photos, but they did the job. And I think that as long as you're getting pictures and remembering to do so, that's going to be the biggest thing. Because if you don't have pictures, they're going to make you pick more cases. I would also find out where your anesthesia records are stored, because you will have to submit this along with the rest of your case information whenever they do select cases. And so making sure they're appropriately storing this somewhere where you can go back and retrieve them is hugely important. And it also has useful information like your start and stop times for surgery, which they track for every case in your case list. The board will also ask for peer reviews from people in your primary facility. So this is usually the chief of surgery, the chief of anesthesia, and the nursing supervisor. And so it's nice to get to know these people ahead of time so that whenever the board emails them for the peer review, they at least know your name and who you are. And then I would definitely scrub your social media before you have to submit all this to the board in April. So I would Google yourself, go to all the top websites and see what is out there on you. And I would make sure that things are clean and professional, and I would never claim to be board certified. And that's one of the big sticking points of the board. So if you go to one of these websites like vitals.com and they claim that you're board certified, you have to notify them to take it down, because ultimately you are responsible for what's out there, even if you didn't put it there yourself. And in addition, I would not include the ASPS logo with any of your advertisements, because that can be misconstrued as claiming board certification. The medical records department at each of your institutions that you practice at will have to sign off on your case logs to make sure they're accurate and to make sure you haven't added any cases or subtracted any cases. And so I would find out who these people are as soon as you can and let them know about this so that they're prepared, because again, you only have 3 weeks to turn this around. And sometimes it's hard to get a hold of them. They're down in a dark basement somewhere, and sometimes they go on sabbaticals for a long period of time or whatever they do. So I would make sure and have their contact information, try and get their phone number, and have them sign off on your case logs as soon as you can to get that step done. Once the board selects your cases, then you start preparing your books. For me, it was 7 cases. For you, it'll be 5 cases, so don't worry. I would set aside a significant amount of time for this. So it takes a while, and it's during that summertime period, after your case collection period. So I wouldn't plan a month-long trip to Europe during that time. I would really have enough time set aside to prepare your books. And if you find that you're missing something like a photo, a consent, or whatever, let the board know early, and this will result in having 3 more cases selected. And there's really not a lot of leeway around that. Once your books are ready to go and the board finds them to be acceptable, then you're going to be sitting for the exam. And during this process, you're studying your books, and I would have at least 3 external people look at your books as well, and preferably in your specialty. So if you're doing a lot of hand surgery, you should have hand surgeons look at your books. If you ask an aesthetic surgeon or somebody else to look at it, they're not really going to have the same insight. So and make sure that they're hard on you when they're looking through your books, and schedule a time to talk to them about it. Having them email you criteria or critiques is good, but setting up a 30-minute time to just talk to them and go through it and have them run through your cases with you is incredibly important and helpful. And then lastly, when you're thinking about prepping for the unknown section, there's a few different ways that I think are helpful to do this. One is to have a case review book. This is the one that I used. I had no conflicts during this book, but I thought it was excellent. It had enough information in it to where you could get all the things down, and it didn't have too much information, so you got in the weeds. So I thought something like this was incredibly important. And then I also did a board prep course. So there are multiple out there. I did ASPS. There are a few, and I think that those can be good if you're the type of person that can benefit from that. It can also just help you to get into the mindset of studying that fall before the exam, and then you can identify a study group in that cohort. So finding people who are also taking the exam your year, and preferably in people with other specialties or other interests, can be very helpful. So I studied with a microsurgeon and an aesthetic surgeon, and we met once a week for an hour and a half on Zoom and just ran through cases. And I think that can be very impactful. And then whether you're practicing in a group or practicing on your own, I would practice out loud, because a lot of the exam is about how you verbalize the information, and you have to be concise and clear in your communication because it's a short period of time for each unknown. So making sure you're practicing out loud is very important to prepare yourself. And ultimately, just remember, it's going to be okay. Do the right thing, start early and prepare, and everybody should do well on the exam. With that, I'd like to say thank you. And if you have any questions, feel free either during this talk or just email me afterwards. I'd be happy to answer.
Thanks. Now we're going to transition to some practical parts of running your practice.
Hi, everyone. Thanks so much for coming to this talk today. I'm Catherine Hinchcliffe. I'm from the University of California, San Diego, and I'm going to be talking about transition to practice, and specifically building and managing your team. Maybe. Here we go. It is obviously a topic that is predicated on my experience, and so I'm in a big academic center, and if you have joined a private practice or a different practice model, some of this might not apply, but I think a lot of it probably will. So I think this was an interesting thing for me to get used to when I started practice, is the idea, instead of sort of you being one small component, one cog in a very large wheel, you are now like the center cog, and the wheel ends up revolving around you. So there's a lot of components to your team. These are the components of mine. I'm at UC San Diego and Rady, so I have actually two of each of these, which is a little ungainly, but you need a surgery scheduler. Usually you'll have a nurse on your team. There are some benefits to having a nurse, and how you'll utilize it depends on your practice pattern, but nurses can do independent visits, although they're non-billable, but they can take away some of the post-operative care for you. They help with your inboxes. You may or may not have a scribe. You will certainly have an OR lead, whether they're just assigned to your service or a few different services is variable, but the person who's going to get you all your implants and make sure that everything is ordered correctly. Having a medical assistant when you start your practice, understanding who the medical assistant on your team is and advocating for one that has enough time to do your disability paperwork is really important. For your boards collection, certainly taking your own photos is important. But some photos can also be taken by a medical assistant if you feel like you can train them appropriately to do so. They will also room your patients in clinics, so understanding that flow is important to make your clinic run efficiently. You will usually have an admin if you're part of an academic practice for academic stuff and travel. I have another slide coming up about APPs because I think this is a big component to a care team. So I'll leave that for the next slide. And then a clinic scheduler. This is a really important person on your care team, actually, because they will function as the gatekeeper for referral triage. So depending on what kind of practice that you're in, if it's a very established practice and they really understand the referrals you're seeing, this person might have like a clear workflow already. But I know when I started practicing, working a lot with my clinic schedule to make sure that the referrals that were getting to my clinic had the appropriate workup to be there and were appropriate for my clinic was really important. And then this person usually also builds your templates for clinic, which is another huge important factor in clinic efficiency. So how many patients will you see an hour? How much time is assigned to new patients versus return patients? How many double books will you have? And then there is a lot actually of learning to be done about how to build an efficient template that is worth talking to your mentors about. I'm also happy to chat with anybody about it in order to run the most efficient clinic you can. Oops, sorry. A little bit more about APPs. So your usage of an APP will depend on your practice pattern, whether you have an APP at all. But they are a really interesting component to a care team because they can have a very wide scope of practice. APPs are able to do in-clinic procedures. They can bill independently. So not so much in your board collection, but as you transition out of board collection, they can improve access to you getting new consults because they can see first-time consults if it's for straightforward things. They can do some post-op care for you, but again, a lot of these are inside the global period, so being thoughtful about who's seeing those patients is important. What I have really noticed, I've now had 2 APPs in my practice, and I have definitely learned from that experience. The level of independence that your APP can have is really tied both to the complexity of care that you're providing, but also to the amount of training you invest in them. So the more you teach them about what is happening, the more they are able to do. And I think it is very important to train while you are in boards because you have to see all your own patients anyway. So spend that time with your APP if you're able to sort of teach them your workflow, educate them about the patients that you see. And so that way you can really leverage their independence when you get out of your board collection. I think a lot of the idea of building a coalition is something that, you've had to do as fellows, as residents, and sort of through your life. So people have some thoughts about how they might do this. I think things that have been successful for me that I think are important are one, of course, loyalty to your care team. So if there's a complaint filed against someone on your care team or there's a staffing issue, like your first reaction is, to assume the best of the people on your team. And I think that really goes a long way with people. Advocacy and mentorship, it's really a cool thing, especially in big centers, that the people in these jobs don't always stay forever and they have goals and plans, and you're in a unique position that you're able to advocate for them. So if you have like an MA that wants to be a nurse, you can help with that, or like a scrub tech that's going to nursing school that wants to stay in the OR, like you can write them letters and try to keep them there and help retain people that you think are worth retaining, and that goes a long way in both directions. And then, of course, open communication and approachability. Everyone on my care team has my cell phone, text me, text all the time, anytime, and always respond. In terms of managing your team, people have different ways that they like to manage their team. What has worked for me is having a weekly care meeting with my whole team. So I do that on Fridays at 8 a.m. This is just from a couple of Fridays ago, but this is what shows up on all of the Zooms. I Zoom with them every Friday at this time before my Friday clinic. And we sort of go routinely through these 7 items. So surgeries and consults for the week, like inpatient consults. Was the follow-up correct? For the surgeries that I have, is their follow-up booked appropriately? Do they have OT that's booked appropriately? Surgeries for the next week. Do they have the appropriate orders? Is their post-op stuff ordered correctly? My surgery scheduler will go through all of my open cases. So cases where the surgery request is in, but it hasn't been booked. And we'll talk about urgency of booking, where they should go, anything else going on with that. We'll review my clinics for the next 2 weeks. We usually review 2 weeks in advance. So if changes need to happen, it's not happening to patients who are scheduled for the following week. We'll also look at the PA clinic to make sure that there's nothing weird in her clinic. That's a good time to go over inbox messages that the nurses have had trouble to deal with. And then any other questions, concerns, open it up to the team. It takes about 45 minutes every Friday to do this. We'll miss an occasional Friday, but it's pretty consistent. And this is just what works for me. Other people will do post-clinic, running the list, or post-clinic emails, post-call emails. I'll do that sometimes, but for me, it really helps to meet with my care team every week to keep us organized, because it's a sprawling practice between 2 different hospitals, and this is what has been good for me. I would recommend it. Any questions now or afterwards, or email me. Certainly, this was a learning experience for me to build my team and build my coalition, and I'm happy to chat about it further.
Hey, how's it going? I'm Keith Aziz. I'm an orthopedic surgeon at the Mayo Clinic in Florida. I am here to talk to you all about something that is sometimes one of the most tedious topics and kind of least exciting, but probably, one of the more important things that you all have to understand and kind of grapple with as you go into practice. Hopefully you've gotten some level of education during residency and fellowship, but and I don't think I'll be able to cover every single aspect of this during this talk, but I'm going to give as much insight as I can to try and give some guidance. So I'm going to go over kind of the basics of the coding process, some terms that you've probably heard thrown around, like bundling, modifiers, things of that nature, E&M coding, physician classification and why that can become important, and kind of touch on how this affects your practice. And I think we're mostly going to be doing Q&A at the end. I think this combination of words is probably put most of you in this condition, so I'll do my best to try and be as engaging as possible with this. Starting with the basics, what are these codes? They're used to represent unique medical procedures. They're maintained by the American Medical Association, excuse me. And it's a fairly Herculean undertaking. There's a panel that's predominantly made up of physicians. There's representation mostly from national medical societies that constitutes 11 of the 17 members. There's also representation from the American Hospital Association and insurance companies. And then there are 2 non-physician representatives from the Healthcare Professionals Advocacy Committee. The editorial committee itself is supported by an advisory committee, which is distinct but involves any society in the AMA House of Delegates. As hand surgeons, we're somewhat fortunate because we have the potential to have what I would say is a bit more representation than some other subspecialties. As our society, the AHS, the sibling society, the ASSH, and both the general and plastic surgery societies are within the AMA House of Delegates. So, if every single person from the more general societies were hand surgeons, you could technically, have a 3% share of the vote for this process. This committee meets tri-annually, and they review changes, requests, and emerging technologies, and they, kind of consider when to purge outdated procedures. This is again itself like a pretty busy process, and in 2022, over 400 codes were added, deleted, or revised during those 3 different meetings. So it's a pretty large and involved process. In order to generate a new CPT code, which is something that I can guarantee will happen in all of our careers at some point in time, an application has to be filed, and technically anybody can submit this, but it has to have some level of physician support. A lot of device companies are keenly aware of this, and pretty strongly try to incentivize physician advocates. And there's 3 different categories of CPTs codes. Category 1 is going to kind of constitute the bulk of what you are worried about and thinking about, and they're the most pertinent to discuss. They're involved in payment, board certification, both the ABOS and I think we briefly reviewed the plastic surgery boards as well, and pretty commonly used for research purposes. Category 2 codes are really more for performance and quality assurance, and then Category 3 codes have to do with innovative technologies. These Category 1 codes involve some level of FDA approval. They constitute a distinct service that is provided by many different physicians. So if you're one of 5 centers in the world doing an incredibly unique and important technique, it's not going to meet the threshold for code creation. And you'll probably have to navigate through the unlisted code process, which itself can be a bit frustrating. And in order to generate these new Category 1 codes, there should be, I should say, excellent support in the literature, and that's kind of the standard that's applied. Any code change applications are pretty heavily scrutinized, and every society in the AMA House of Delegates, which includes 180 different societies, can provide their input, ask panel members, and it really becomes a pretty big back and forth for this process. Once these codes are approved, then they are sent to yet another committee, which then tries to determine the value for the code and provides guidance to CMS. This committee works with yet another committee that determines the value for reimbursement, and that's because the RVU includes a work component, which is what we do, a practice expense component, which is something I think we've become increasingly thoughtful about, and professional liability cost. I sometimes wonder if that professional liability costs component is going to be revised up at some point in time when you see things like the malpractice awards that are given for like professional athletes, but I think that's something for another time. Once these RVUs, have a specific value, there's a way and a formula that you can use to determine payment. This is also why, see reimbursement rates differ based on the portions of the country that physicians are located in. Each RVU has a geographic cost adjuster, which then itself has a conversion factor, and then that malpractice, premium conversion factor can also or be different based on the geography. So all of these are kind of combined together: your work, your practice expense, and the specific geographic cost indices for that location, and multiplied by a conversion factor to dictate your payment. This is really important because the Medicare physician fee schedule is used to determine the insurance payments for billing, and almost all other insurance companies, even the non-government insurers, will use the Medicare physician fee schedule as a benchmark because it's incredibly costly to develop their own. Usually it's a percentage portion that dictates it, and that's why this is a process that has a lot of time, effort, and thought behind it, and is somewhat open to all the different AMA societies. So that's all the procedural coding. What about your in-clinic coding? And this has actually changed pretty recently. So all you really need to do is become incredibly familiar with this chart. I would not hesitate to, put this somewhere that's easily accessible for you. I think early on, I referred to this quite a bit in my practice. It's on the AMA website, and it kind of goes through the decision-making. This is the medical decision-making chart. So for the evaluation and management coding, a lot of these recent changes, I would argue, were quite beneficial for, a lot of people, especially us as hand surgeons. They've eliminated some of the physical exam and history components that were somewhat unnecessary and unlikely for us to achieve. I think it was probably pretty uncommon for hand and upper extremity surgeons to develop or to obtain a level 4 visit prior to these changes, because the number of body systems that you had to evaluate and document were quite onerous and somewhat impractical for the type of practice that we often have. And also the level 1 new patient was eliminated. So again, there's medical decision making versus time-based. I think, most people that I talk to, and certainly myself, only use medical decision making. But just to briefly review time-based, it does include non-face-to-face time, so like care coordination, review of documentation, talking to other members of your team, or like family members of the patient if necessary. And there are very clear ranges and cutoffs for what you need, and there are kind of incremental adds that you can have beyond the maximum amount. Going back to the chart, once again, this is the medical decision-making chart, which I think most of you will use pretty heavily. There's kind of straightforward, low, moderate, and complex, and it really has to do with the amount or complexity of data that you're interpreting, synthesizing, and also the risks of complications or morbidity or mortality for your management. So most surgical discussions involve almost will always escalate it to a level 4 of some sort. Now, I can't say all, but most. And I think that's for these two reasons. The definition of what a, chronic illness with exacerbation or progression, and, technically exacerbation or progression can mean failure of non-operative management, and then discussion of the risks associated with minor surgery. And those are two of the different categories of the medical decision making, and you need two of these three categories: the number and complexity, elements of decision making, or risk of complications. And you will get both of these with surgical discussion. And an acute complicated injury, even in a patient like with a fracture or something of that nature. So the definitions of complexity are listed here, but basically something that's self-limited or minor is something that is transient, not going to affect their health status, and is going to resolve spontaneously. Anything that's chronic is something that's going to last for at least a year and possibly longer. And something that is stable, and this is different than how a lot of us think about things, is something where the treatment goals have been met. So anybody who's returning to your clinic, I shouldn't say anybody, but most people who return to your clinic will often return because they feel as though their symptoms are progressing, worsening, or not adequately managed. Most patients, in my experience, tend to, if they're happy with their outcome and how they're progressing, will kind of be happy to just contact you only if and when things get worse. The amount of data to be reviewed has to do with interpreting the test documents, etc. When you're talking to an independent historian, this is something you'll encounter more in pediatrics, or if you're taking care of geriatric patients. These are people who are not the patient, who are providing some component of the history. And the independent interpretation has to be of tests that are not reported separately. So you also have to be really careful if you're in private practice, and if you don't have a radiologist who is reading and interpreting your radiographs. If you try and use this to argue for a certain level for the data analysis portion, that's effectively double dipping. So if you're also billing for the radiographs for the read of those things. So if you have a radiologist, you're an academic center, the radiologist has read it, and then you add your own interpretation, that does qualify for the data component. But if you're in a private practice setting, you have your own in-house radiographs, you don't have somebody reading them, and then you bill for the read, you cannot also use this for the data component. Okay. Risk of complications, I am not going to read through this entire thing. I think that it's really, that chart is actually quite helpful and really summarizes things quite well. Moderate risk can even be adding prescription drugs, even non-steroidal anti-inflammatories that are typically over the counter, but you're prescribing, could be a moderate risk of morbidity. Failure or engaging in some sort of physical or hand therapy would also potentially meet this moderate risk of morbidity. High risk is something that I think is unlikely that we're going to encounter too often in our practice, unless we're doing things like free tissue transfers, brachial plexus surgeries, things that are a bit more complex. But it's going to be a little bit less common for most people in their day-to-day practice. Some of the other benefits to the changes in the evaluation management charges are that the reimbursement amounts have increased somewhat by as much as, depending on the particular visit you're talking about, 45%, and it's made a pretty significant difference. I actually have a colleague who's a general orthopedic surgeon who feels as though because of these changes, he's able to make more in his clinic than he is during his OR days, which I think is fairly uncommon. Whenever you're billing for evaluation management recommendation, you will need a diagnosis code. Candidly, you need this for everything, for your CPT code, for your E&M codes, etc. So just to touch on briefly, ICD codes are maintained by the World Health Organization. Again, mandatory part of billing. There are about 70,000 codes, and interestingly enough, despite the fact that we have things like hit by objects from aircrafts, we still don't have a diagnosis code for intrinsic tightness. So, there's always more that could be added. These are just some common ICD-10 codes that you may or may not use. I'm just going to kind of quickly cycle through these. I think most electronic medical record systems will have some ability for you to relatively quickly search for and add these to your clinic visit. For modifiers, which is another important thing to be aware of, will kind of have a large role in both your OR and your in-clinic billing. I listed the 5 most common modifiers that I utilize. 25 is for significant separately identifiable evaluation management. So that's cases where you've seen a patient in clinic, but then you also elect to proceed with an injection to make sure that you can be reimbursed for both. The decision for surgery is more common if you're seeing patients in the emergency department and proceeding to surgery shortly thereafter. I also take general orthopedic calls, so I use this a lot for my hip fracture patients. And unrelated E&M in the same post-operative period. Every now and again, patients will bring up new or different complaints or issues that they would like to talk about. Post-operative management only has to do with when one physician performed the post-operative evaluation of another physician's care, and then distinct procedural services, which, candidly, the difference between the 59 and 51 modifier is really not too clear to me sometimes. I also talk with our coders and billers on occasion just to clarify, and sometimes they will just change things on the back end to help inform me. They've occasionally told me that it has to do more with the specific insurance that you're billing as opposed to whether or not one is right versus the other, because there seems to be some redundancy. Other ones that are important are the 22 modifier, which again is important to consider the insurance that you're billing, because some insurance companies will not reimburse for the 22 modifier. Bilateral procedures being 50. Multiple procedures of 51. These are only for standalone codes. So if you do a trigger finger and a carpal tunnel release, for example, the assistant surgeon, I have personally used it when I'm doing free flaps or brachial plexus cases, but that's an important one to consider when you're there for over 80% of the case. The minimum assistant surgeon, I call it the phone a friend code. That's if somebody kind of pops in to help you with something, or you encountered something that was unexpected. And then the assistant surgeon is really more in circumstances where you typically have a resident and they're either at education or unavailable for other reasons, and maybe one of your partners came to help you out. Bundling is also something that's important to be cognizant of, because some CPT codes will include a descriptor like, with bone graft, for instance, for the scaphoid non-union. So you cannot bill for harvesting the bone graft and use the CPT code concurrently. I think this is an important one to touch on briefly, because there are going to be some changes coming down the pipe, I believe, for CMC arthroplasty, where at least our coders tell us we will probably no longer be able to bill for the concurrent tendon transfer if you utilize any form of ligament reconstruction with tendon interposition. So that will probably a change in the not too distant future. The physician classifications becomes important if you're a part of an academic institution or a multi-specialty practice. If somebody has seen one of your partners and then is going to see you, this allows you to determine if you can bill for a new or if you have to bill as an established visit. You can have a partner who's a sports medicine physician, a partner who's a general orthopedic surgeon, and you as a hand surgeon can all theoretically bill for a new patient evaluation if your taxonomy reflects your physician classification as a hand surgeon. So that's something to also talk with your billing team about, and they can often help you to reclassify if it is worth the time and effort from your practice perspective. And ultimately, this is important because your documentation dictates your payment. You cannot bill for what you did not say that you did. And if you didn't say that you did it, you didn't do it as far as insurance companies are concerned. It's really important to have complete and accurate notes. It limits and prevents, in some cases, upfront denials. About 35% of denials from insurance companies are estimated to be improper. And I know that that rate will probably go up because insurance companies are starting to leverage and utilize artificial intelligence to do kind of auto denies. Any peer-to-peer that you do, if you ask, they will probably admit that, oh, this may have been denied by our computer program initially. Documentation beyond the billing side of things does become pretty important if you get drawn into the medical legal world. And in that respect, I will say that what I have been told by one of my colleagues is it's technically okay to edit and addend your note up until you receive notice. As soon as you receive notice, it's pretty poor form to try and addend or change things. It's really important to also be careful about your documentation if you're a second or third opinion. One of my partners was the third opinion, and some of the phrasing that he used in his note, which was not the most positive about the index surgeon, drew him into the lawsuit for a lot more time. He did not provide care for this person. He was not himself being sued, but the way that he phrased things really, made his day, a couple of days, a lot longer for him than he wanted it to be. So, in closing thoughts, these E&M changes only apply to the outpatient management. It still does not apply to inpatient consultations or emergency department consultations. You still have to use the old system for that, which is confusing and unfortunate, but it's just the way it is right now. I would make sure you update or adjust your templates to reflect common portions of medical decision-making in your practice, if that's how you bill, which I suspect many of you will. If you do not document these, again, your reimbursement will suffer. And the inpatient system will require those bullet points for the history and physical exam to support the level of evidence. All right, happy to take questions, in the chat, or I'm sure towards the end we'll do a Q&A session. Thanks for your time.
Thanks.
Awesome.
So now we're going to transition to kind of outside the clinic. And just so you know, if you have any questions, feel free to type them into the chat. If it's easy to answer, we can type in a response, or we can save them for the Q&A at the end. Thanks.
All right, thanks, Keith. I didn't see any of the participant number go down during the billing talks. That is a job well done. We're moving on to talk about professional growth. I am Steve Niedermeyer. I'm a hand and upper extremity surgeon in private practice in Dallas, Texas. These are my disclosures. Yes, we still do have to grow. We have chosen a profession that does require longitudinal learning and longitudinal growth. As Keith just outlined in the previous talk, things continue to change for us as surgeons. Objectively and subjectively, we also have to continue to improve ourselves by continuing to grow. And there are so many ways in which, when I was given this topic, that I thought of ways to grow. And for the sake of time, I boiled it down to these 5: knowledge and skill, involvement in hand surgery, plastic surgery, orthopedics, teaching and mentorship, community and your brand. How do you grow yourself in your new geographical area? And then personal. And the last talk is going to go into more work-life balance and ways you can grow personally. But I did just want to touch on it because I do think it is important to grow yourself personally when growing professionally. We won't reopen the wound of board certification. That was done very well by Paul and Jordan earlier tonight. So I'll talk about growing through experience early in practice. I think it was my first patient I saw in practice. I had never seen anything like it. That is not this case, but it just illustrates the point that you will continue to grow even from patient number 1. This case was, I think, my 4th surgery out of fellowship. It was a lovely woman who had a total elbow that went on to aseptic loosening of her ulnar component. And this is a surgery I had never done before. And it was, like I said, I think within the first 10 surgeries that I did, using an APC ulna allograft, and revising her total elbow. I illustrate this case because, again, it was something I hadn't done before, but you utilize the resources around you. Read the literature, go onto ViewMedi, Handy, look at some surgical technique videos, and phone a friend. My mentors are probably sick of me calling as much as I do, but this was one of those cases I felt I was trained to tackle, but didn't have the experience of doing this particular case. So I called them and got their advice and their recommendations. And here she is post-operatively. She hugs me every time I see her. I see her every year to make sure she is not aseptically loosening again. And she's a happy patient. But 1 year later, I get this that comes into clinic. And so I maybe didn't have to phone a friend as many times as I did the first time, but having utilized that experience from that first case gave me the tools necessary to treat this Montesia fracture, non-union. And she came in first post-operative visit, being able to hug her daughter with her dominant arm for the first time in 4 years. So makes you feel good when you can tackle the hard stuff, utilize that knowledge and experience to grow and continue to treat patients with those difficult problems. Growing your knowledge through society offerings. There's 2 hand societies, there's orthopedic societies, plastic surgery societies. Don't hesitate to go to those annual meetings, attend these webinars like we're going through this evening. There are so many ways to grow your knowledge base through society offerings and through industry. And we'll touch on society offerings first. Every single society has an annual meeting. The AAHS is always somewhere sunny and warm in January, and it's around my birthday, so I always attend that one. But that shouldn't be the only one you attend. ASSH, wonderful ways to continue to grow your knowledge and your skill set. There's more and more pre-courses that are involving cadaver dissections, labs, to get your hands on new technology, to get your hands on techniques that you might have not experienced in training, but you're seeing those patients now in your practice. So utilize everything that your societies have to offer. Ways to get education when you are doing those maybe literature reviews for those cases you need to polish up on. They're right here. You go to your society websites underneath the education tab. There's multiple ways to brush up on your knowledge and your skill set. Here's the example from the AAHS. And of course, how to get hand-e videos through the ASSH offering. But then through industry, not just the meetings, your reps continue to bug you about, hey, we're going to Palm Springs in May, we want you to come out. Hey, we're going such and such in June. But also locally, the top right images, that's my daughter with my rep and my PA as we're practicing doing a proximal hamate autograft transfer for a proximal bullous scaphoid non-union. Just down the street, your industry has the ability to have cadavers, have labs, give you the equipment you're going to be using in surgery to simulate your case so you can grow before you take that patient to the operating room and put them under anesthesia. But it's always also nice, those industry offerings that do take you to nicer places, to hone your skills, to try new things, to practice the surgeries you have coming up. I can't tell you how many times I've taken them up on those opportunities and just practice cases I know I have coming up. So that way it's not the first time I might be doing that in my patient. And then through literature on the JAHS, JHS Go, hand journal from AAHS and PRS. Just because you are not going to a steakhouse and doing journal club doesn't mean you should stop reading. There are tons of things being published every single month so that you're prepared to give your patients the information with the utmost up-to-date literature, but also can help change your practice for the better. I can't tell you how many times I tell patients, I think it was an article last fall or maybe the fall prior, that talked about CBD cream for thumb CMC arthritis. You get those patients all the time, thumb CMC, they tried Voltaren, the injections aren't working, they're doing their brace thing, but they're not ready for surgery. And it was something I didn't know about or utilize in residency or fellowship. And then an article came out in JHS, and I recommend it to all my patients now who may be not ready for surgery, but need that extra something to get them through. Even if you can't read, the pictures are always nice. And then I can't emphasize this enough. I think there was a good functional MRI study that showed that like embarrassment and mistakes were the #1 trigger for your short and long-term memory. I showed you a cool case at the beginning and those went great, but I've had plenty of mistakes and struggles and tough cases that my patients and I have had to work through together, and learning from those and growing from those is I would say the most important part of growing your knowledge and your skill set. You don't want to be the guy or gal making the same mistake over and over. You want to be able to tackle those tough cases, tackle those failures and those mistakes with your patients, let them know that you are caring about them and that you will work through this tough time with them and then grow from there. So that way these mistakes are something you learn from. Let's move on to involvement. Again, multiple ways to get involved and grow through involvement through your societies. Most are right there as get involved. ASSH, it's get involved. AAHS, it's also get involved. I think that I have grown a lot through my involvement with national societies, making relationships, talking about those cases. I remember at the end of a subcommittee meeting at AAHS, I was talking with Jordan, who was my co-resident at Ortho Carolina, and one of his mentors from Duke, about a case just that I was getting ready to gear up for the following week. And being able to get involved grows you professionally. You're able to start to learn more about maybe how things work with your societies, how things work politically, coding and billing. There's tons of ways to continue to learn through your involvement nationally, but also locally. This is the Texas Orthopedic Association. They host meetings as well, which kind of gives you the ability to advocate for maybe hand surgery at your state level. Talk about ways that maybe certain practices are combating decreased reimbursement with private payers, or how they're structuring their clinics. Tons of ways to get involved, so that way you can learn from them, but also get involved and then help to give back to the community afterward. Teaching and mentorship. So a lot of you, this is your job now. These are just pictures of me throughout residency and fellowship with my mentors. And when you first start out, you go from being taught to now probably having a resident or an intern or a fellow on your service in the first month. Utilizing those mentors that you had in residency and fellowship is invaluable to your professional growth as a mentor, because those now young minds you want to shape into being maybe not hand surgeons, hopefully hand surgeons, but whatever surgeons they will become, you are going to be responsible for giving them the tools they need to succeed. And even if it's not your job, I have always had a passion for teaching, have found myself in private practice, but through industry offerings and giving lectures several times a year. But also, I want to highlight this image down at the bottom. This is me teaching 2 residents who I was able to be colleagues with during fellowship. And 2 years later, they're going into hand fellowship, and I was able to, through a resident and fellows course, teach them. So just because you go into private practice, it's always one of those things. Am I private practice? Am I academic? I really like teaching. If I go into private practice, I'll never have the opportunity, but I'm teaching all the time. And I love continuing to be able to give back. And so just because you don't select an academic position doesn't mean you don't have the opportunity to grow as a teacher and a mentor for your colleagues, your peers, and also those young surgeons coming up behind you. This was a unique experience. So this is me back in Charlotte just a couple of months ago for our mock oral boards for our fellows who graduated last year, who sat for their boards this July. I reached out to the faculty and again, love teaching and wanted to have the opportunity. So you can also create your own opportunities to continue to teach and mentor if it's something that you're interested in. I find that teaching and mentoring has not just helped me give back, but also helps me grow. Every time I am in a teaching or mentorship role, I learn at the same time too. And then you get this whole group of people you never thought you'd be friends with. This is the Golf Hand Society Club, ages from I won't say to me. My first year in practice, I was part of this group, and a wonderful community of teaching and mentors that I continue to learn from. Building your community brand. This is my personal website. You want to start thinking about what are some of those things you want to tell your community that you're offering. Are you going to offer unique things like brachial plexus peripheral nerve surgery? Start to kind of cultivate how you want to introduce yourself to your community. So that way, when you get there, you can tell whoever manages your practice or your department's website what you want to say about yourself. This also helps a ton with search engine optimization, what you want to do, how you want to shape your practice, how you want to grow in your community. It could start all right here with keywords and phrases that you want to be known for, that you types of patients you want to see in your community. Put it out there so that way when people search for you, that's a good place to start. And then utilize your marketing and sales person, your Laura Redmond. This is Laura Redmond. She is our chief marketing officer for my practice, and she is incredible. Whatever I would like to do, even if she doesn't know how to immediately do it, she gets me in touch with the hospital systems in my area. If I want to reach out to PCPs, drop off some lunches, give some business cards, or again, you're in a community that hasn't had a brachial plexus or peripheral nerve surgeon or somebody who does amputee work. That's a way to utilize your marketing resources to get the word out that, hey, I'm in town, I offer this. Do you want me to come by and talk to you more about it? Here's a couple of examples. Top left is me talking to the Dallas Amputee Society about targeted muscle reinnervation. This is my daughter and myself and my partner and her daughter at a community event, giving patients information about our practice, but then also fun stuff like being able to be on the football field. This is a football field, but this is a soccer game. We are the team physicians for a minor league soccer team in Fort Worth. So being able to grow in my community by giving back to the local soccer team. And then also fun stuff. Your practice or your university can sponsor golf outings, and you could be instead of in clinic on a Monday, out there with your partners, hitting the links. Personal growth. I know we've got to talk about work-life balance coming up, but I can't emphasize enough. If you want to professionally grow, you need to also personally grow and take care of yourself. This is my team up there in the top left, my PA, my MA, and my scribe. The solar eclipse came perfectly over Dallas, Texas. So we ignored patient care for about 15 minutes so that we can burn our eyes into the sun. This is us with those special glasses so that we did not burn our retinas. This is my family down there at the bottom left. My wife and I just came back from a trip to Switzerland. My friend and I going on a trip to Bandon Dunes, my yearly golf trip with my high school buddies. Again, there's a work-life balance talk coming up, but in order to take care of your patients well, you need to take care of yourself well. And so continuing to find ways to balance yourself, do things you love doing, taking time for your family, if you have a family, can't emphasize, if you're healthy with yourself, it makes it easier for you to grow professionally. With that, I hope I didn't run over on time. I will kick it over to work-life balance. Thank you guys so much.
Good evening, everyone. Thanks again for taking the time. I've been tasked with an anchor leg, so please bear with me. I'll try to get through it relatively quickly. Sorry, I just realized my video is off, but it should be good to go now. So the title of my talk is Navigating the Crux, How to Balance Professional and Personal Life. I don't have any relevant disclosures. So the first thing you think about when you're done and you graduate is, am I really finished? You think about all the advice you've been given throughout the years and you think, man, it's still too fresh. Thinking about residency and doing residency were two totally different things. And you have these raw emotions from the doing of residency. And you still really feel like this. And then you have moments like this. And then you have a few of these sprinkled in every once in a while. So then how do you even think about balance in this kind of an environment? So how did we get here? So I'll tell you a little bit about myself personally. How did I get here? My grandfather was a referee. He brought my family to Las Vegas after refereeing that fight with Muhammad Ali and Joe Frazier. And then I did undergrad at UNLV in Las Vegas, and then I did med school in Reno, and then I finished plastic surgery in Denver, Colorado. And then eventually I made my way more east, and I made my way over to Mass General, and Moose and I got used to climbing some plastic rock, and then I made a new family over at MGH. So then you think finally you're done, and it's really, and now what? We're the type of people that appreciate delayed gratification. You don't really stop to think about all of your accomplishments at each time point, because for a lot of people, it sort of just feels like a means to an end. And then now you have all of these choices that you never even realized were available to you before. When you think about it, you've done so much schooling, time commitment, time that you make, time that your family makes, and it's a huge sacrifice. So now how do you integrate balance and wellness into this system that seems just inherently really imbalanced and unwell? So I thought about the most imbalanced portion of my life and things that I enjoyed the most and things that I got to do the least during training, and things that I wanted to do the most of during the summer before it started. just as mentioned in the talk before. So what did I do? I got to enjoy fun employment. So for 8 weeks, I traveled through Europe. I got to climb, and I got to spend the most time with my family that I ever have, and basically since before I left for college. So I got to climb a bunch, and then I got to come home to my dream job and a lot more tan. So that just brings the question again of now what? How do you start? How do you actually become an attending? And obviously we've all been taught that there's an art and a science to medicine, but how do you do that as an attending? When or how do you actually hit your stride? So I'm sure you've been in this situation before where you're trying to please everyone. Your stress levels go up and then the quality of your work goes down. And being a brand new attending is daunting. It feels really overwhelming. Boards looming. And then you think, how can I commit to doing only things that are truly important when you don't want to let people down because you're just starting and you don't really know how to balance everything yet because you've never done it before. So this book was a recommendation from a good friend and a mentor. And I was struggling with how to balance, quote unquote, everything. And instead of spending energy making millimeters of progress in a million different directions, like the photo on the bottom, this book really tries to get you to focus on things that really matter so you can gain momentum towards accomplishing things that are just truly vital and going in one direction. So sort of the premise of being an essentialist is to do less, but to do it better. So you realize you can't do everything. You have to choose what you'd like to focus your efforts on and do them really well. And that results in more satisfaction, not only for you and your personal life, but also for work. And you actually find that you get more accomplished. So that brings me to the title of my talk, The Crux. What is a decisive or most important point at issue? And for me, there are many similarities between that and my hobby of rock climbing and hand surgery in my practice. So, but in both rock climbing and surgery, if you get too worked up, if you get too stressed out, your palms get sweaty, you shake, you blow the move, you fall, you get distracted, you lose control of the situation. So you have to think about, what is the crux? We're intelligent people, but for some reason we choose to have the undisciplined pursuit of more all the time. And in a climb, you have to find your beta. And a beta is sort of how you get through a crux or how you get through the difficult part, how you can get through the climb. So whenever you're faced with a problem, whether it be difficult patients in clinic, a tough case, or if you're climbing and it's a tough crux, you have to figure out what beta is best suited for you. And now suddenly you have all these choices again. You got to choose your schedule, how you spend your time. What do you want your practice to look like? When can you have OR days or clinic days? You get to make all these choices that you never got to have as a resident or a fellow. So again, I think about the principle of less but better. What's meaningful for you? You have to make the time for what's important for you. And you have to give yourself permission to be more selective in what you choose to do. And for once, you have to celebrate the things that you enjoy rather than being busy as a measurement of your importance. We don't always have control over the options that are presented to us, but we do have control over how we choose among them. So one thing that was really important to me coming into practice, and I think something that really helped, is a mentor. Who do you go to and for what? And I think one of the best pieces of advice that I got from one of my mentors is you have to have different mentors for different things. It's not fair to both the mentor and the mentee for somebody to go to the same mentor for everything. You go to the same doctor for everything, they're experts in different things. So you wouldn't want to go to somebody that primarily does breast augmentations for your elective head surgery, right? So another thing that's really important is managing your expectations. What's your definition of success and what trade-offs and things are you willing to quote unquote give up? You have choices. For the last decade of your life, again, you've had other people basically making decisions for you. And when you want to try to say something, you're a little bit afraid to say anything because you don't want to be labeled as any of the following. So who gets to make that decision? In that book that I mentioned before, he mentions that if you don't prioritize your life, somebody else will. Something that's also very important and prevalent in medicine, regardless of the level that you're at, is decision fatigue. So again, it's mental overload. You have a deteriorating quality of life and deteriorating decisions because you've had a long session of decision making. And I don't know if necessarily that the decisions get easier, but over time, I've certainly found ways to employ more mature coping mechanisms. So for example, you can identify what things can trigger you and how you can cope with them. So sometimes what does that look like after 10,000 decisions that you've made in a day in clinic or a hard day in the OR? Is what do you want for dinner? That's something that really drives me nuts sometimes. So how do you get over something like that? Is you try to find a routine and you set boundaries. I think it's really important to do these two things because for the routine, you can find a way to cope in a healthy way so that you can go about your day and you can still recover from that well. And that goes hand in hand with setting boundaries. You have to be able to say no, and you have to be able to make that choice. And you also have to realize that people will actually respect you more for being able to say no, rather than trying to do a million things poorly at once. Another concept that I think is really important is work-life integration. And this was introduced to me after working on ASPS's Project Well by Dr. Losi and maintaining meaning in medicine in his lecture for physician wellness and resiliency. And he introduced this concept of instead of work-life balance, you really have work-life integration. So instead of trying to have two separate things where you're really fighting yourself for thinking, okay, this is a work thing and this is a life thing, you can maybe sometimes enjoy both together so it's not so terrible and you can spend the time doing things that you want to do together. So one of those instances for me is I had the great opportunity of being able to work with these awesome people and combine a few things that I'm interested in, which is work, research, and climbing. So with this team, I was able to work on a research project that somehow brought me to be able to fly out internationally to work with the International Federation of Sport Climbing to become a medical delegate and work on relative energy deficiency in sport. And I was able to be a medical delegate for this event in Guiyang, China just last week. So I'm still recovering from the jet lag for that. So another thing that I think is really important is you have to think about how you're spending your time, right? Because if you have so little free time, how do you best spend it without feeling like it's wasted or pointless? You have personal goals, you have professional goals, you have hobbies, and then you sort of feel frustrated that you quote unquote don't have enough time for anything or to be as good as you want at something or to get the results you want. So I think people have probably already heard of Marie Kondo and think more about her organizing things in the house. But you have to think, does it spark joy? Is it enough to bring you joy such that even if you're not the best at it or you can't spend as much time at it, does it really just give you the ability to be rejuvenated and continue doing it? And the most important thing, I think, is protect the asset. And that's you. You spent so many years getting here and you have to enjoy the moment. You have to take care of yourself. And I think it's really important that when you think you're too busy to think, you have to create space, even if it's small, so you can concentrate. You have to find a distraction, free time and space and time for you. And that allows you to generate new ideas and be more inquisitive and actually engaged. So I think something that we sometimes do poorly is we forget to celebrate the little things. So for me, something that I used to do in residency and in the fellowship and now is I would always try to set aside time for something that I wanted to do every day, every week, every month, and maybe a few times a year. And unapologetically, you should make time to do that because if you don't, you're not going to be yourself. And if you can't take care of yourself well personally, you're not going to be able to take care of patients at your best. So one reminder for me is my grandpa, he's 90 years old, and here he is still sending me videos of him working out. So whenever I feel like it's more of a punishment to work out, I remember, okay, I can still do it. So things that keep you going. This is one of my patients. He's in his 60s, and he unfortunately stuck his non-dominant arm into a snowblower, and he sustained these injuries. This made me think of something that I think is really important that I actually ended up doing as an attending myself, which was advice to set aside a corner for yourself in your office, where when people do nice things for you or give you nice things, you should put them in a corner so you can look at them when you're having a tough day and you're feeling really beat up and down. So this patient sent me an email, him and his wife about a year out, and they just wanted to give me an update. And they said really kind things, and it was really nice to hear from them. And they sent me a bunch of photos in an unsolicited email. So that was really nice that they were thinking of me and still remembered my email address. And they even sent me some of the maple syrup from his farm. Here are a couple of other things that I sort of integrate into my work-life balance. That's a pull-up bar outside my office. So whenever I pass by it, I sort of feel guilty and I have to go and do a couple of pull-ups. And then I feel better about myself and then I can go about my day. The middle is actually a photo of my dog that a distal radius patient drew for me. And then on the screen right is one of the senior residents. And we capitalized on some of these professional grade fake tattoos that one of our admins brought to the office. So one of my patients that I operated on bought me this really thoughtful gift. And he was one of the patients that happened to be in the lineup when I put the fake tattoo on. So he put this best fake tattoo thing. And I thought it was kind of funny because they thought that it was actually real and they could just see more of it because I had scrubs on, because usually I wear a suit in clinic. This is from another one of my patients who's 8 years old and had a chronic wound after an ORF of the distal radius. And she was also in my tattoo lineup, and she brought me this card. And on the bottom right there is some fake tattoos. And she realized that I like Star Wars, because I have a few Star Wars things. And she bought me fake Star Wars tattoos. That's pretty nice. So remember, protect the asset. Yes, you are really finished. Don't forget how you got here. Take a break if you need it. Think about what's essential to you. Remember work-life integration instead of work-life balance when you feel like you don't have time to separate things. Celebrate the little things. And don't forget what keeps you going. Thank you very much.
Great. Thank you. All wonderful talks. And I mean, such a breadth of information from board preparation to setting up your clinical practice to setting up your professional life and your personal life. And I really want to thank all of our speakers, Dr. Greer, Dr. Garib, Drs. Hinchcliffe, Aziz, Niedermeyer, and Tuanyo, for all of their insight and definitely a lot of work that went into preparing and giving these presentations. So for concluding comments, Dr. Jane.
Yeah, thanks, Ines, and thanks to all our wonderful speakers for really awesome and informative talks. I mean, these are just fantastic. I think this webinar we watch online again and again. Even after being in practice for about 15 years, I've really learned some new things from all of you. I'd like to thank you, the audience, for spending your evening with us, and invite you to join us next month for our next hand-in-hand webinar series with the American Society of Peripheral Nerve. Good night.